السلام عليكم ورحمة الله.
Waalaikumsalam warahmatullahi wabarakatuh.
Good morning. How are you? Are you okay?
Good.
Alhamdulillah. Alhamdulillah. So we can start our inshallah lecture by Al-Kitab, Al-Fatiha. Can you see my screen?
Yes, Dr. Mossad.
So today we are going to speak about an important lecture about the neonatal infection and the sepsis. Right side, the upper one, you can see this is a full term baby. Y5B3 is a full term.
Yes.
Can you hear me, Afika?
Yes, I can hear you.
Why this baby looks full term?
Why? Because the baby size. However, we need to take the history from the mother.
Okay. Okay, so baby size, what else we can see here? We can see head's flexion position. It's flexing his limb. If preterm, he will be lax, extended it. Okay. Also, the skin is well formed. If we look, we can see the nipple, which is well formed. In neonate, it will not like that. Okay. Also, if we are able to see the genitalia, it will be well descended testicles and well formed labia majora. And we can see some four creases. In spite of that, this baby looks to have lead. He needs supplementary oxygen like that. Okay. So who can comment about the second picture? What is this? I didn't need to give lecture in one way. Please try to share with me. Otherwise, I will open the attendance and choose one by one. We can see from this picture what is the most important point here.
Rashes and pustule.
Yes, Ammar. Yes.
There is multiple rashes and pustules.
What is the type of this rash? Macule, bacule, avar.
Macule and papule.
No, this looks like
pustule.
This looks like vesicle.
Vesicle.
Yeah, it is very important. If you notice like that, in spite there is some cases like pustular melanosis, but sometimes if it is herpes simplex, it is very dangerous. If we didn't pick it, it has high affinity to go to the brain, and because mortality and morbidity. Sorry. If anyone not using the microphone, please switch it off. And let us go for our study goal now. We need to definition also what is the common clinical manifestation. How can we diagnose? Of course, we are going to discuss the pathophysiology and the treatment and prevention. Hoping, inshallah, you got a good home message with you. Neonatal sepsis means is a bacterial infection in the blood. Okay. Early onset sepsis occur in the first 2 to 3 days only. Okay. Late onset, it will be from 3 days and above until maybe 1 to 3 months. To say neonatal, it is occur in the first month of life. What is the importance of that? The early diagnosis of sepsis is important. Outcome. Inshallah, any one of you are coming to work in the ICU, you must remember him and
Sorry, Dr. Mossad, we can't hear you clearly. Probably your internet is not stable.
internet is not stable. No, it's okay in front of me. Can you hear me now?
Yes.
Yes or no?
Okay. So it is very important to remember that the sepsis in the neonate is a clinical syndrome. Okay, accompanied by bacteremia, means the bacteria in the blood occurring in the first months of life. But remember that the late onset sometimes can occur up to 90 days. The risk factor, it may be for the early one, is the maternal infection like GBS, premature rupture of membrane, chorioamnitis, okay. After that, healthcare associated infection, which is known as nosocomial infection, okay. It is 100 times common than the congenital infection. NICO as a whole has the highest rate than any other area, okay. At least 20% of the children are diagnosed as neonatal sepsis. Now we have a problem all over the world, something known as MDRO. What is MDRO? It is multi-drug resistant organism. Multi-drug resistant organism. That's to say, it is very sensitive to our initial line of treatment, second line, third line. So that we need to evolve another more antibiotic. What is the cause of that? We will discuss after. Just remember MDRO. As we speak before, the incidence for international is different between countries, okay? But Malaysian in 2007, they said between 5 to 10% per 1,000 live births. In the United States, it is 12, okay? Mortality of untreated sepsis, take care please, mortality of untreated sepsis is 50%, and the morbidity, meningitis occur in 1/3 of the cases. There is some ethnic difference for that. So remember, sepsis is considered a bit common cause of mortality and morbidity. According to the age, the preterm has high incidence of infection. Why? They are relatively immune compromised. Even their skin is not so mature. There is immaturity of the immune system. There is decrease the passage of maternal antibodies. We'll see after that. Most of the antibodies coming from the mother to the baby will pass after 28 weeks or like that. So if the baby delivered early, he is poor for gaining these antibodies. Okay, the incidence of sepsis is significantly high in infant with low birth weight, specifically if less than 1 gram, which may be 26 per thousand. Okay, the risk of death of meningitis from sepsis is higher in an infant of low birth weight. So remember that the preterm, the low birth weight, and even another, they have a high incidence of infection. 6, remember that in ICU, the male is less lucky. Sepsis are more, and even the overall prognosis in girls in ICU is better than boys. So congratulations for our staff. Okay, you can see here, this is just what will happen, okay, for anyone to get immunity in the first few months or few years of life. Okay, you can find here circulating antibody before the delivery, okay, and it will come from the mother and it will decrease before just the first year. At the time the baby is trying to building up his own antibodies. Okay. At the same time, he is trying to make equilibrium. If the baby delivered at birth, like he is 28 weeks, he got a less of antibody. Okay, that's why the total intestinal antibody, the child own antibody, all this can be affected specifically if no vaccination also. So remember this one you need to study because it will guide you how we are challenged to help the children with infection. We are trying to help him, but sometimes he is unable to help himself. Can you hear me or not?
Just now, your voice is not clear.
I don't know what is the issue in the hospital and the Kulliya. Okay. If anything, just send me a message on the WhatsApp so I can try to settle the issue, or I may try to open my own.
Sorry, Doctor. I think
me-
our Wi-Fi at Mahalah that have the issue. It's unstable.
Is it yours or mine?
I think it's ours.
It's yours. Okay. Can you hear now?
Yes, we can hear you.
So, okay. So I think anyone can switch off the video if it is making some burden. Even for me, I will switch off the video for a while, so it will not affect the strength of the presentation. Where is the video here? Stop video, okay. Remember that for neonatal infection by age, the early onset, it means it will appear before 72 hours. Late onset after that. And as I told you, sometimes it can be expected up to 90 days. The maternal obstetric complication usually occur is most common at that. Okay, the prematurity also, it is very common. Manifestation, it is multi-system disease. It means The microbe will go to the blood, so it can circulate, so it can cause pneumonia, it can cause symptoms, systematic symptoms, it can go to the brain like that, okay? The late onset, it will occur after 72 hours. Maternal and obstetric complication can be, but it is uncommon, okay? Varies, it can occur for premature or mature one. Usually, this is the most important. The late onset can be multi-system, but also can be focal. I mean, the child will come like with pneumonia, with osteomyelitis, like that. You must remember that there is different organism according to early or late onset. Early, you can see in front of you, the top is GPS, means group B hemolytic streptococci. I didn't prefer to make a lot of abbreviation, but in some points. After that, Escherichia coli and other. But the top one in the late onset is the cons, which means coagulase negative staph. And the other type of staph, Escherichia coli, Pseudomonas, Acinetobacter, all this can be also responsible for the late onset. So remember, please, the sequence of the organism according to the early or late onset. So group B streptococci or streptococcal agalactia is the most common organism associated with early onset sepsis. It is gram-positive encapsulated bacteria with many serotypes, about 10. Serotype 3 is the most common. Colonization of this is the most important. This organism can be colonized in the gastrointestinal and genital tract. The infection with it for the infant can cause respiratory distress, cardiovascular instability, meningitis, shock, and even death. So this is the sequence, can be just respiratory distress. So if you find the baby started to have respiratory distress without rationale for that, like the baby has meconium, the baby has premature RDS, so take care, you must suspect sepsis early. And they used to say you can't be a good neonatologist unless you are able to smell the infection. This is Escherichia coli, which is gram-negative. Usually, it came from maternal, urogenital, and the gastrointestinal tracts, which is the second most cause of neonatal sepsis in term and most common in very low birth weights. Can cause meningitis, can be accompanied. Remember that gram-negative are very strong, and usually it will accompanied by meningitis, thrombocytopenia, and even death, even in the first day of life. So if you suspect neonatal sepsis by gram-negative, it is no matter to consider according to the antibioma and antibiotic unit or according to the maternal history. This is the Listeria. It is known to affect about like that. It has many serotypes and high risk if the mother consuming raw milk or unpasteurized milk product. So take care about that, please. If the patient, if the mother consuming raw milk like that, so at this situation we are preferring to use ampicillin better than CPEN. Ampicillin are very effective against the Listeria. The late onset, as I told you, the most common one is the cones and the other staph. Okay, you can find it especially in very low birth weight. Staph we find in the human skin for nurses, for doctors, for families, and in the mucous membrane, like the mucous membrane of the nose. formation of a biofilm protect bacteria from antibiotic. And this is one of strength point for the microbe cons. He will put like biofilm which protect him and help to invade the immune system. MRSA, methicillin resistant staph, about 30% of staphylococcal infection in the premature. Very, very dangerous, and it is resistant to methicillin. At that point, we need to upgrade like vancomycin. Other gram-negative organisms like Escherichia coli, Citrobacter, Pseudomonas, all this can really very strong because the death rate with this infection is more than 50%. Usually it is transmitted by hand of a healthcare worker. And then colonization of the GIT, and then contamination can be also contamination of the TBN, can cause even during catheterization, bladder or anyone. So take care, please, as we will discuss after that, washing your hand before touching the babies will prevent the infection. Complete aseptic technique for any procedure must be strictly obeyed. You are not allowed to cause harm to the baby by introducing the infection. Remember that if you are going to like insert the central line and you are not obeying the infection control rule, you will bring infection directly into a central line, which means severe septicemia, and it may be death. So please remember that one, okay? Especially gram-negative and Pseudomonas has a higher mortality. Citrobacter can cause brain abscess. The Candida infection is the third cause of late onset sepsis in premature infant. The risk factor are low birth weight, giving broad spectrum antibiotic. That's why we are using the antibiotic obligatory, but there must be judicious use. We are not giving it open, otherwise it can bring for us a worse organism, which is a fungi. Okay, Candida albicans and non-albicans, they have higher mortality and neurodevelopmental delay because the fungus can affect the brain, can affect the kidney, and they make something known as fungal ball, which is very dangerous. So again, to revise the early onset sepsis, okay, it is due to GBS, colonization, or chorioamnitis of the mother. Remember, chorioamnitis is the top important because it will through the placenta to the baby. Any premature rupture of membrane, okay, or prolonged rupture more than 18 hours, maternal UTI, multiple pregnancy, or preterm. All this is more risk factor for the early onset sepsis. The late one, late onset sepsis, is breakdown of the natural barrier in the skin and the mucous membrane, or prolonged use of a catheter, or invasive procedure, okay, even endotracheal intubation, if not completely under aseptic technique. Of course, can be presented by NEC or prolonged antibiotic use, okay? Remember that H2 receptor blocker, if we use proton pump inhibitor, can decrease the acidity of the stomach, so the baby even cannot kill the organism coming through the gut. So this is for the risk factor from the other situation, but for neonate, if he is a preterm, because he didn't got the maternal antibody, or his immune system also is not so competent. So remember again that the infection for the baby can come through the placenta, can come from vertical or horizontal, okay? So if through the placenta, we are suspecting virus more than bacteria. And remember that the torch screen, okay, are very common and must be considered with other organisms like HIV and other. Sometimes not through the placenta itself, it came by vertical one, which is bacterial like GBS, E. coli, Listeria, and other organisms like chlamydia and herpes. It may be horizontal bacteria, which I mean now it is coming from the health worker, which is known as nosocomial infection. Mostly it is gram-negative like Klebsiella or Staph, Pseudomonas, Proteus, Serratia, rotavirus, like that. So the baby are very weak and his immunity are not so strong. So please take care to get history about the mother if she has chorioamnionitis or have congenital infection, if she got like bacteria like GBS or Listeria or other chlamydia or herpes. At the same time, the healthcare worker infection are very, very dangerous. It is the same area just to remember, okay? The viral infection can come through infection of the blood, which coming from placenta to the baby, okay? Some organism can coming through the genitourinary tract of the mother, okay? There is other infection like Toxoplasma Listeria. So the baby can be infected from many sites and anywhere, and you must be able to get a detailed history. Where is the site of the infection? From where this baby can get, and what is the suspected infection? Is it bacterial, viral, fungal, or other? Okay. So here is hematogenous, and there is ascending infection. Ascending infection, of course, it will occur if there is premature rupture of membrane like that. You see now, through any vessel, the microbe or the bacteria can go through the vessel, so it will infect everything. What is the manifestation of neonatal sepsis? It is non-specific sign and symptom. Okay? It is non-specific. Sometimes it can be presented by respiratory distress, can be presented by meningitis, pneumonia, bacteremia, UTI, osteomyelitis, like that. So you must have a good index of suspicions. Who can comment about this baby picture? Can you see it dying? Don't hesitate. Don't worry. Just try to tell me what you can see.
Is the baby?
I think the
Who will-
vessel is visible and the skin is very smooth and shiny. And maybe not keratinized well.
Okay, good. So number one, we can see that the skin itself is very shiny and delicate, and even we can see the vessel through it. It means this baby may be premature. Okay? Even we cannot see the nipple very clear like that. So this may be the skin of prematurity, but at the same time, we can find that the abdomen are distended. Can you see the arrow of mine or not?
Yes, we
So
can see.
now yes, now you can see that the abdomen is distended, and there is some changing hue discoloration, like blue to green discoloration of the intestine. This is a very important, which is known as maybe necrotizing enterocolitis, NAC. Okay, so the initial diagnosis of sepsis by necessity a clinical and became imperative by beginning the treatment. This is a very important. We must, if we suspect treatment, you need to collect the investigation and start treatment on the spot. Why? Because it is not like adults. We can just ask anyone, come please, I will do blood culture for you, and you can come after 48 hours, 3 days, 5 days to check the result. If you did that with the neonate, he will not check the neonate himself because the microbe will be very strong than the baby. So our aim, if we suspect infection, we are going to collect the investigation and start antibiotic, and it preferred to be within 1 hour. Is it clear? Don't wait for the result of the culture. So clinical signs of sepsis are not spelled sepsis. So please, if you suspect sepsis, you must collect the investigation and start directly even the first line, which is the Cibin and the Genta. Okay, it will take about 36 hours up to 48 hours to get the result. If it is negative at that time, we can start more than hyper. Okay, changing in the behavior, which is very important. If the child started to be irritable or his tone are changed, please take care about that. The skin also, if there is poor perfusion, cyanosis, mottling. Mottling, I mean the skin making like marble. It is very dangerous one in neonate. Pallor, petechiae, jaundice, even sometimes it can be pathological one. Feeding a problem, if the child was full feeder and start now not to tolerate the feeding or start to vomiting, diarrhea, or abdominal distension, or ileus, you must take care. It can be a sign of infection. So it is not only that specific one, but here the temperature, the behavior, the skin, the GIT, the cardiovascular system. Many child, if he started to get infection, he will get tachycardia and tachypnea, okay, and the other respiratory distress. Some of them can get apnea. Okay, of course, for hypotension and bradycardia are very dangerous because we have 2 types of shock, compensated or decompensated. If the child started to get hypotension, it is very dangerous. Okay, also gastrointestinal tract, he may get vomiting, diarrhea, abdominal distension, even hepatosplenomegaly. Metabolic, disturbance of the blood glucose, either hypo or hyperglycemia, can go with sepsis with metabolic acidosis. Renal, if the child started to get urine output, usually we need the urine output between 1 and 2 ml per kilo per hour. If it is less than that, we must take care. Okay, hematological, of course, as we speak, can be jaundice, pallor, thrombocytopenia, petechiae. All this can be signs of sepsis. Less common can be seizure, which convulsion. DIC, I mean disseminated intravascular coagulation, is an important sign, especially if the baby started to bleed like that. Petechiae, hepatosplenomegaly, jaundice, meningitic syndrome, irritability, lethargy, poor response to of the baby is very bad sign. Abnormal neonatal reflexes, hypotonia, all this can be signs of sepsis. So it is very broad sign and symptom. Okay. Usually, if you are speaking about congenital infection, which mean the organism coming through the placenta or the blood of the mother, like torch, okay, the manifestation will be growth retardation. So please, if you find a child who is IUGR, try to consider this. It may be congenital malformation, and sometimes there is probability of fetal loss. Postnatal infection, it can be presented by meningitis, septicemia, conjunctivitis, pneumonia, all this, okay? Remember again that perinatal infection also can cause symptoms like this, okay? In our unit, person-to-person contact can cause group B streptococci, listeria, Escherichia coli. Remember, in the eye, he can get chlamydia or gonorrhea. Eye infection are very dangerous and must be treated because it can cause blindness. Okay, even breast milk is not completely clean or expressed like that, and it can transfer also HIV and the cytomegalovirus. The umbilical, okay, can be infected by staph or tetanus. Remember that the peri-umbilical redness is considered very, very, very urgent, and we must admit the baby and give him antibiotic because the infection here, like cellulitis, it is around the entrance of the UVC and the UEC. Okay, so please, you need to revise this slides. It is very important. If we suspect, as I told you, if I suspect any neonatal infection, I must collect the blood sample, especially the full blood count and blood culture like that, and start on the spot the antibiotics. And this is the investigations, which can be blood culture, which is the gold standard. Okay. There is the rate of positivity is low. Why? Most of the ladies are given antibiotic during admission to the hospital, and it's the blood volume sometimes can affect, so it cannot be all cases of positive culture. Okay, we need sometimes to do blood culture, CSF culture if you suspect it is accompanied by meningitis. Urine culture may be better after the third day. Of course, the chest X-ray must be done if the patient has respiratory distress. For disseminated herpes virus, it is very important if you found the rash in the eye, in the mouth, in the skin, or in the anus. Take care. Any mother has herpes simplex in her genitalia, she is going to deliver cesarean section. Okay. And we must be very cautious. They prefer even to do it before rupture of the membrane. Okay.
Doctor, can I ask a question?
Yes.
The blood culture, we do it at a specific site and a specific number, or just once?
No, it will be once. But you are breaking a vein for blood 1 centimeter or slightly more for neonates is enough. Okay, so I mean I will break and got the blood culture number 1. Then if I need to collect full blood count, anything I can collect it. And must under complete sterile technique. Sometimes you may need to collect the blood for culture if from central line, if you suspect the line itself is infected. Okay.
Okay, thank you, doctor.
So remember that the gold standard is the blood culture, but rate of positivity is not so high. Sometimes we need to do aerobic and anaerobic. Usually may not be available in every place. Okay, are appropriate for most of the bacterial pathogens. Anaerobic culture are especially important in neonates who have abscess. Okay, process in the bowel involvement or massive hemolysis or refractory pneumonia. At the time, we need to go for anaerobic. Also, if we suspect fungal, we are going to add fungal infection to be checked. If we suspect viral like herpes simplex, we must add it. Okay. Usually, the culture of the will give us a result within 36 to 48 hours. Okay, which is very important at the time of the patient are stable like that. Many clinicians are comfortable to stop the antibiotic. Okay, if the patient are completely stable, not need oxygen, tolerated feeding like that. Okay, here is your point, Afika. Single site blood culture are effective for neonates. Urine culture, Vara, the most important if you are going to collect urine culture, the first few days, it may be many of the babies has bacteriuria. So they have some bacteria, but it is not infection. So it can misguide the one unless we have strong evidence to suspect UTI at the time. Okay, so the urine culture, if you need to collect, it must either suprapubic, I mean, I will bring a syringe and over the pubis, I will go for injection and suck some urine, or through catheter, which is very important, especially in late onset. This is the full blood count and differential count. It is very important, and sometimes you need to do it serially. I mean, I repeat it to see what is going. Like if I have thrombocytopenia, if I have neutropenia, which is very common to find, I must know what is going. It may be thrombocytopenia today is mild. As you know, thrombocytopenia means decrease platelet than 150. Until 100, it will be mild. Between 100 and 50, it is moderate. Less than 50, it may be severe. So if I didn't repeat, I don't know. It may be today is 110. Tomorrow I found it 30. So it is very dangerous and must be serial disease. Okay. Also, neutrophil left to shift are very important, and the ratio of immature to total ratio of the neutrophil will help us to diagnose sepsis. Remember that the normal blood count doesn't rule out sepsis. We found leukocytosis, neutrophilia or neutropenia, thrombocytosis. Yes, it is a good point. But if you didn't find, they tell everything is okay, no need if the patient has clinical sepsis. The C-reactive protein, okay, it is an acute phase protein associated with tissue injury, are elevated in some point from 50 to 90% of an infant with systemic bacterial infection. CRP level is secondary to macrophage, T cell, and adipocyte production of the interleukin 6. This is especially true infection with abscess, cellulitis, and deep tissue. But it is a sole is not a sign of infection unless the baby has clinical one. The CRP level is not recommended as a sole indication of neonatal sepsis, but may be used as a part of sepsis workup or as a serial study. I mean, I will see the CRP now, it is 2. I will repeat, after 24 hours, I found it 10, I found it increasing. This is very dangerous, okay? That's why the clinical judgment is very important. Sometimes it looks for you that the consultant working have discrepancy. No, it is like that. The baby is our target. His clinical behavior and his clinical signs sometimes is more important than the clinical signs. Okay. CRP can help to determine the duration of the therapy. He said, assess response to the antibiotic to determine the duration of therapy or identify relapse of the infection. Clinical sepsis with only positive CRP need a short course of antibiotic. if it is the only one, okay? Other, which is a very important, known as BCT, procalcitonin, okay, and serum amylase. Procalcitonin now is available in our hospital. It is a peptide of calcitonin product produced on the monocyte and in the liver, may be more sensitive than CRP. And it is more specific to bacterial infection than the viral infection, and has shown to be useful after the 24-hour, and also it will help us to stop the antibiotic. There is another like cytokines, chemokines, and other biomarkers. But now we have CRP, we have also procalcitonin, we have the neutrophil markers, okay, which is it's a number and mature to immature, IT ratio, okay, immature to the total one. Especially IgM in the serum. In the serum may help to determine some intrauterine infection. You know the torch screen. Usually IgG means transmission from the mother, but also its number sometimes may help us to take decision about starting treatment. Lumbar puncture and the CSF finding is in infective neonatal meningitis are follow. Very important, the white count, especially polymorphonuclear, elevated protein, and decreased glucose, and positive culture. So this is an important marker. The white count, the protein, if you ask it for how can you diagnose? You said it is white count, it is the protein, is it the glucose ratio? I mean, the ratio of the glucose inside the CSF to the blood or plasma. It must be more than 60%. If it is low, it can go with infection. And of course, the positive culture. Sometimes we need to do PCR for the herpes simplex. As I told you, if you find the vesicle or the mother has herpes infection in her genitalia like that, it is very important to consider this one. And you are going to start acyclovir, but there is herpes zoster, herpes simplex viral PCR is reserved for an infection with CNS abnormality, skin vesicles, and CSF abnormalities, or for infant who has clinical symptoms but have negative culture. So it is very important to consider the PCR for herpes simplex. As I told you before, please, we are trying to define the investigation to lab, sometimes bedside testing, and specific one, okay? We spoke before about the lab and some bedside like dextrose, because dextrose will guide me, blood gas. If I did it, it may be the patient has metabolic acidosis or respiratory failure or like that. It is very important, okay? Now the chest X-ray are very important to diagnose respiratory distress, 2TN, pneumonia, or other, okay? CT or MRI of the baby may be needed in certain points. Okay, especially if the patient has hydrocephalus or suspected abscess or infection. Sign of chronic disease like ventricular dilatation, multicystic encephalopathy, brain atrophy, all this we may need to do MRI. You must read, please, one article, the mastery of choosing between CT and MRI. Because I found most of you in the exam are a bit clumsy. When to choose CT, when to choose MRI, what is the benefit of CT, what is the benefit, MRI, what is like that, okay? Of course, in neonate, we have a very good opportunity to do head ultrasound. It can rule out intraventricular hemorrhage, ventriculomegaly, like that. Ventricles, which is very before delivery. Some of them do it at 28 weeker and repeat it at 34 weeker. If the mother is a carrier, we must take care about that. Okay, so there is universal GPS screening for all malignant women. This is the second one. If the patient has symptoms before that, we can do it. Early recognition of chorioamnitis and antimicrobial therapy for the mother, it will prevent the infection to the baby. Sometimes we are giving a prophylactic antibiotic like penicillin or Cibin or cefazolin 4 to 6 hours before delivery. So it is very important to try to prevent, like the most important one, like RDS. What is the best thing for RDS is to give maternal corticosteroid, dexamethasone or betamethasone. Okay, it is the same. It will prevent RDS and the intraventricular hemorrhage. Here, if the mother has GPS, you must screen for that and treat it, please. Number one, treating the mother. Number two, teaching the staff about infection control. And really, I am dealing with infection control as a religion point. If you are washing our hands to do salah, we need to wash our hand not to infect a very small baby or even any patient, adult or children. Because Islam himself who said you must pray, it was said by the Prophet, not allowed harm for anyone, please. Okay, so hand washing are very important. Infection control, central line epilepsy. Now it is very important. There is lines when you are inserting a central line, you must fulfill it. Okay, and what to use for hand washing, I think you will present it for your clinical skills. In the past, we are speaking about intravenous immunoglobulin. Now they said it is not documented. Okay, anti-staph monoclonal antibiotic, no effect. Granulocyte macrophage colon stimulation, which is known as GM-CSF, not proving efficacy. Okay. Caltamine also no proven. Probiotic, no proven efficacy of neonatal sepsis, useful as a preventive of NAC. So this will give you an important guide before a longer while, like someone of me now graduated for nearly 35 to 40 years, there is a lot of options. Now they said after randomized control study and evidence-based medicine, we found it is not proven. Of course, lactoferrin, okay, it's a glycoprotein of human milk. Okay, it will increase cytokine production in the gut and associated lymphoid tissue. A small study saw reduction in the both fungal and bacterial infection, but we need large. But lactoferrin can be. What is fluconazole? Yes, antifungal, very important. It is effective in the prevention of Candida species, especially in a very low birth weight infant with no neurological developmental outcome effect. But there is also some resistance we may need to change. Okay, so lactoferrin can give some benefit, fluconazole, some consultant are using even oral nystatin as a prophylactic, and it works really also. As I told you, for the management, we must be able to smell the sepsis. If suspected neonatal sepsis, treatment should be immediately started after rapid sample collection of a septic profile. Start antibiotic as soon as possible. Try to monitor the cardiopulmonary situation, cardiopulmonary support, intravenous nutrition may be very important because the baby are susceptible to good NEC. Okay. We may need to give blood product, like if the patient has thrombocytopenia or abnormal coagulation, to give him, or anemia, you need to support him. Of course, the temperature and the dextrose must be adjusted. So this is your goal. Once suspect, collect, start the treatment, monitor, support, IV nutrition, okay, transfusion if needed. This is a very important. What about the antibiotic? They said you must have judicious use of an antibiotic. Okay? Because multi-drug resistance, it will come if you are using haphazard many antibiotic, if you are giving it for a long time without documentation. Okay? So if you give it for a long time, it can be cause drug resistance. It can be causing Candida, which is disseminated one. It can cause NEC. It can be vancomycin resistance, because if you come to the top antibiotic for us, which is the vancomycin, became resistant, so we are in trouble. So first line, we are starting ampicillin and gentamicin. It is the empiric treatment for suspected early onset. Ampicillin resistant, Escherichia coli, and we can give cephalosporin third generation, like cefotaxime, because ceftriaxone is not given to the neonate also. It can cause biliary mud like that. Okay. For late onset, we are going to start by vancomycin. Why? Because the cones sometimes are resistant to other methicillin resistance. So this is our first line. Okay, if we suspect Escherichia coli, we will go for this, and the vancomycin will be used for late onset. Of course, Ampho-B and fluconazole can be used for antifungal of choice for neonatal candidiasis. There is now new antifungal, okay, which is very effective, can be chosen if it is available, especially micafungin. So let us revise. We will start empiric initiation of an antibiotic when suspected bacterial infection, and to discontinue when they haven't been identified. I mean, after 48 hours, there is no growth and the baby are stable. Or switch antibiotic based in the susceptibility, which is the top important. If your unit are able to give it to you early, it changes the antibiotic agent to those with narrowest one. It means I'm going to use narrow specific antibiotic, but you must define the duration of the antibiotic. How? Here, if there is early onset proven sepsis without meningitis, you are giving here giving it for 10 days. Okay. If late onset without meningitis, we can. Can you hear me or not?
Yes, we can hear.
Yes, doctor.
Okay. So please, if it is early onset sepsis without meningitis, it may be from 7 to 10 days. If it is late onset without meningitis, we prefer to be 10 to 14. If meningitis early or late onset, it will be started from 14 to 21. Some gram negative, it is 21, maybe more. Some cases, if the child got osteomyelitis, we may need to give up to 6 weeks or more. Okay, so it depends upon the result of the blood culture and the onset. This is HAI, which is healthcare acquired infection or nosocomial infection, is 100 more common than the congenital infection. And it is known that the NICU has the highest rate than any other place. Okay, it may be up to 12% will get it. Many pathogens are developing MDRO. So take care, please, about that, as I told the infection control policy. This is a very nice from our pediatric protocol about the congenital syphilis. It is very important because it is stated that 90% is a transmission rate if the mother has untreated primary infection, can occur anytime during pregnancy. And clinically, it is asymptomatic about 60%, but can get hepatomegaly is the most common sign, skeletal or osteitis or periosteitis, okay, lymphadenitis, maculopapular rash, high contagious one, rhinitis, like that. So all these are very important to go through the history of high index of suspicious, because if you suspect, you must go for non-trigonomal RRR or vidral, okay? It is very important. And the other test, which is trigonoma specific test, all this will help you to diagnose the congenital syphilis. The management, we need up to 14 days of aqueous penicillin or brocaine penicillin to protect the child. Again, I said sepsis, okay, and the infection. This one, it is the infection of the mouse with, who can comment for this tongue depressor?
Candidiasis?
Sorry?
Candidiasis, there is a whitish or a trash.
Yes. So this is infection, not sepsis, because it is still here, unless it is a part of systemic infection. Even if you find the candidiasis, some babies who are immune deficient can start by that, but you will find systemic infection with it. So now it is just infection with candidiasis, which can occur in this baby and affect his sucking ability. So take care about that. What about this one? Another candidate answer, please. That is the one which we discussed before, which is the umbilical cellulitis. It is very dangerous, and the baby must be admitted to get antibiotic. This one, we must rule out herpes simplex, which is very dangerous. Our home message is careful history and meticulous physical examination, along with appropriate investigation, are essential for diagnosis of any neonatal has signs or symptoms of sepsis. Just a while. Yes, Alawin. I am giving a lecture to the student. Maybe after 15 to 20 minutes, I will contact you. Okay? Okay, bye. Bye. So, history, physical examination, investigation, guided. Please, if there is prematurity, if there is maternal history of chorioamnionitis or fever or GBS or UTI, leukocytosis, all this. Early suspicious and the monitoring and the intervention and the accurate management can prevent a lot of complication, mainly septic shock, and prevent, of course, prevention of healthcare associated infection is our goal. And remember, for every patient you can get reward from Allah. At the same time, if you didn't wash your hand and go through infection control, you can be punished because Allah will not accept to cause harm for others. And this is just, I found it now in up to date, the other signs or other finding can be with neonatal sepsis, jaundice, because early jaundice, especially in the first 24-hour or prolonged one, can be significance of pathological jaundice. So it may be present in 35% of cases. Enlarged liver, poor feeding, of course, or vomiting or abdominal distension, or even diarrhea can occur with this number. At the end, we are just praying to Allah subhanahu wa ta'ala. He let us reach Ramadan while all of us, inshallah, and all of Muslims are in the best of health, iman, and happiness, inshallah. Just prepare, open your Quran. Don't wait until the first day of Ramadan, please. Okay?
Okay, Doctor.
Extra like etiological agent, we are speaking now about group B streptococci, but we must, as I told you, Listeria suspected, staph, enterococci, other organism, cons, and now they are shifting from group B streptococci in some area like America, declined about 80% in the United States with the use of intrapartum antibiotic. This is the point which you speak about before. Using intrapartum antibiotic will decrease it. Okay, there is non-bacterial, as we speak, like herpes simplex, entero viruses, and Candida. It is very, very important. Okay. Thank you. And now it's your turn if you need to ask any questions.
I would like to confirm for the inflammatory marker just now, do we need to do both CRP and procalcitonin, or we only choose one?
Really good question. Because this is something, this is speaking here about CRP and it's some limitation and its benefit, but BCT, I think it is better to come like this. Here is the procalcitonin, which is very important. I didn't want to upload you by that, but they said it is a very, very important. Okay, either with CRP or alternate to it to diagnose the infection, and it will help us because it is usually come with bacterial infection, especially if you suspected bacterial, and sometimes it can guide us to when to stop the antibiotic. Usually we are using serial CRP, and we are using one of that procalcitonin. If we find it still high, we are another approval, and then it will help us. Okay. You see, he said here, procalcitonin have some utility in guiding the duration of antibiotic therapy in a neonate with suspected sepsis. A multi-center randomized control use serial BCTM testing guide for antibiotic therapy. Okay, in term and preterm, with suspicious of early onset, infants were assigned to 1 or 2. Like, yeah, it is a good study for that. Okay, so you can use it alone or together if needed. But it is a bit expensive. That's why most of the doctors are thinking before requesting it, especially if you are in semi-governmental hospital and the patient may need to pay. Okay, any other question?
Mossad, I have a question. For the thrombocytopenia in neonatal sepsis, is there any in which level of the platelet that we start to intervene, and what kind of management that we usually give for the thrombocytopenia?
Yeah, yes. Thank you for who is speaking. Shamil. Shamil. Okay,
Yes, I am.
Shamil. This is a very good and important question. Number one, if there is clinical bleeding or like that, no negotiate. Even the platelet is moderate like that, I will treat. Okay, no one will tell you you are wrong. Okay, but for the patient, if he's stable and no signs of bleeding like that, okay, many prefer to wait and see and repeat. I mean, repeat the investigation. But the most important point here, you must go through the protocol in the unit you are working. Maybe if you are working in Malaysia, even between unit and unit, you will find a different concept. If you go to America, I said, no, don't start now, just repeat after 6 hours and close observation. If the baby started to bleeding, give the treatment, platelet like that. If not, just repeat after 6 hours to be able to decide. So really, in the neonate, there is a very wide gray area. The most important to know what is the confirmed and non-negotiable decisions. And for the other, you must go through your units. Alhamdulillah, we have here pediatric protocol, which specify many points about the transfusion specifically. So you can go through the pediatric protocol. And I used to say, Shamil, the one who has protocol, he looks that the one has his father. He has a backbone for him. So try to please put this pediatric protocol in your pocket and in your brain. It will help you. Okay.
Okay, thank you, Dr. Mossad.
You are welcome. I'm hoping for the next lecture to make it live. If I know that you can come to the lecture hall 3, I was preferring just to discuss together and negotiate and prevent anyone to feel bored or the internet is poor like that. Inshallah, hoping soon we can see you, inshallah. Any other questions?
Doctor, just now, prolonged antibiotic use can cause sepsis. Is it due to resistance?
Not can cause sepsis.
Late onset.
Because resistant organism, I mean like fungal infection, can precipitate to fungal infection in the patient himself. And also it will cause the antibiotic because you are using the antibiotic a lot. So the microorganisms try to make his own defensive mechanism. So it will try to resist this antibiotic. So it will start to give us methicillin resistant. And after that, vancomycin resistance. And after that, multi-drug resistance. So this is the issue. If your patient in your hand finished his job and he's okay, with a short course, you need to go. It's just you are for his rule for the time. Don't it is better. No, it is not like that in a few days, it will harm the old. After you coming to you in I find you need with this microorganism. So sometimes you need to change your lines of antibiotic to prevent now because the microbe know it and became resistant. Antibiogram. Usually it must be done about 6 months or yearly. We can take decision to change it to a more sensitive antibiotic. But take care, prolonged unneeded antibiotic can cause more resistance and more fungal infection. Is it clear, Aja?
Yes, doctor. Thank you, doctor.
You are welcome. Any other questions? Okay, so inshallah, hoping I can see you soon in the hospital. I think there is one group have teaching with me on Thursday, or hello?
Yes, group 5, doctor.
Hello? Can you hear me? Sorry, are you busy this afternoon, this group, or not? Do you have another lecture?
We have
this
lecture.
afternoon?
Lecture. Yes.
You have lecture. As Ira, he has congenital operated heart disease, and she has epilepsy, and she has some neurological abnormalities. It is a very nice case. I hope it can stay until Thursday. Let me see. Tomorrow, inshallah, if I found it still there, even I may ask my group to come maybe after 5 to see her tomorrow, inshallah. Okay?
Okay.
Thank you.
Thank you, doctor.
Assalamu alaikum.
Thank you, doctor.
Thank you, doctor.
Assalamu alaikum.
Assalamualaikum.
Alaikum.